Welcome to week 2 of Advocacy, Ethics, and Public Policy. Today I'm going to be providing an overview of the Affordable Care Act. It'll form a baseline for us that we can use throughout the course because we'll be returning to the law frequently as we go through each of the major issues in the syllabus. This presentation is a little longer than the other ones will be. I ask for your patience on that, but I think it's important that we all start with this baseline of understanding about how the law works. I'll be covering these issues. First of all, 3 main components of the Affordable Care Act, and then I'll move to some other provisions that affect Catholic health care. A little bit of time on other sources of reform. The Affordable Care Act is not the only reason that we've got a lot of change going on in the healthcare system today. And then I'll close up with some minor points on what we're expecting to happen with the ACA and its performance so far, although we will save a more detailed discussion of the political environment and the repeal and replace efforts for when we get to the intensive. This last point I'm actually not going to go through, but I'm going to leave you with some slides and ask that you take a look at them because we'll be using them in future sessions. So let's start with the 3 major components of the Affordable Care Act. First of all, it's designed to increase coverage and to do that in part through insurance market reforms, to make insurance more accessible and affordable via an expansion of the Medicaid program, health insurance exchanges, and then various insurance reforms. And we'll be going through those. This component of the law was in response to the concerns at the time and the pressures at the time around the growing number of uninsured leading up to its passage. Secondly, there's a series of payment and delivery system reforms that the Medicare program is switching to pay for quality and efficiency instead of volume of care, with physicians and hospitals now being subject to a number of both mandatory and voluntary payment incentives. This part of the law was in response to a dual concern. One was the rising health care costs that appeared to be unsustainable, rising at 2 to 3 times the rate of inflation for employers and the government. This is the effort to try to bend the cost curve, as we've talked about, with the knowledge that when Medicare makes major changes, frequently those transfer then over to private insurers as well. And then the other response here was to the quality concerns around the unevenness of outcomes and quality in the healthcare system. And then we'll wrap up with a brief discussion of how the law is financed. So starting with the coverage issues, I want to set a baseline here with before the Affordable Care Act was passed, how is it that the American public was getting their coverage or not getting their coverage? This slide shows that half of the total population was getting insurance coverage through their employer. Medicare, of course, is there for the elderly and disabled. Medicaid and other public programs for low-income populations. Then you get the group called non-group insurance. These are individuals and small businesses that purchase insurance directly from insurers, but not in the large groups that can be formed by employers. This is where most of the focus of the Affordable Care Act is, because this particular market for health insurance has been experience rated, meaning that insurers were basing their premiums that they would charge to individuals and small businesses on the actual experience or risk of who they were covering, rather than community rating, which is how insurance started out in the 40s and 50s, where everybody is charged the same regardless of their health status. What this means is that insurers in this part of the market were competing based on risk selection. Now, this is a term we're going to be using throughout the course. Risk selection, adverse selection is another variety of it. You'll hear different terms used, but it essentially means that insurers are incentivized, or were incentivized up until the passage of the law, to try to avoid people who are sick and attract people who are well. It's not to be derogatory about the insurance companies themselves. This was the way the incentives worked in the non-group market for many years. States regulated it to some degree, but not consistently. And what it meant was insurers would look for ways to avoid those sicker populations by denying coverage, the pre-existing condition issue, varying the benefits. For example, if you offer a gym benefit in a package, it means you're more likely to attract healthy people that are going to use the gym. And then, of course, raising premiums based on experience. So for small employers, if there was a single employee where there was cancer in the family, the insurer would often come back the next year and say, well, look, because of the experience, we're going to have to bump up the rates. This was happening both for individuals and small employers, and so the Affordable Care Act actually tries to address both. Now, that left 13% uninsured before the law was passed out of the total population. Unlike most perceptions of the uninsured, this group is mostly a working population. In fact, about 2/3 are either working or living in working families, but they can't get insurance because their employer doesn't offer it, or they otherwise can't afford it. That group, research has repeatedly shows, is more likely to postpone or forego care, leading to more severe and expensive conditions. One of the major reasons why we as a Catholic Health Ministry have pushed for universal coverage over the years and pushed for coverage of this group. Of course, we know that by having that large group of uninsured people, we create a cost shift where other people in the system are picking up those costs, especially through hospital care. So insurers, employers, and others basically pick up the cost when somebody comes in and does not have that coverage, and then the financial hardships for the families themselves. So what did the law do? Here's what it did in order to get expanded coverage in place. I'm going to start at the bottom of this slide, which shows the projected percent of non-elderly by the Congressional Budget Office in the year 2020. I'll start with the employers. The law for large employers really left things largely in place and didn't do a lot. It did create a fee that large employers would have to pay if they did not cover their workers, so it was a mandate for the large employers. But otherwise, there weren't a whole lot of significant changes. And most employers, of course, were already providing that coverage anyway. For the small employers, less than 50, they are not required to offer coverage under the Affordable Care Act. There's a tax credit available to them, and then they can buy coverage through what's called the SHOP Exchange, which is the Small Business Health Options Program, but they use the acronym SHOP for that particular program. Then we have the Medicaid expansion, where the eligibility for Medicaid went up to 133% of poverty. We'll see more about that in a minute. You'll sometimes see reference in Barr's book to 138% of poverty. Don't be confused by that. It's just because there's a 5% disregard built into the formula, but we will refer to it as 133%. And as you know, about a year after the law passed, the Supreme Court ruled that this expansion would be optional for the states. Then you have the marketplaces, the exchanges, where individuals can pick a plan from an exchange, and insurance plans are competing with each other based on their quality and price and trying to attract people into their plan. This is subsidized up to about $98,000 for a family of 4 on a sliding scale. And then you have the equivalent for the small employers called the SHOP program. And then finally, it was always intended and expected that there would be a group of people who end up not being insured when it's all said and done. That was because there would be people who would choose to pay the penalty for the mandate, to pay the tax penalty rather than get coverage. There's a fairly significant group that can be exempted from that mandate. And then undocumented immigrants, as you know, were not covered, were excluded actually from being able to purchase coverage on the exchange and get the associated subsidy for that. So let's look now more closely at how these different coverage pieces built under the law. So this is a chart that shows current Medicaid eligibility for a very typical state in the United States. I mean, when I say current, I mean prior to the Affordable Care Act. And you'll see along the bottom the groups of people who were covered. pregnant women, children, parents, and caretakers were covered under the Medicaid program, but by and large, childless adults were not. And then on the left side, you've got the income levels. And you'll see that, that for a typical state, for example, the 44% of poverty was the cutoff for parents and caretakers, but 200% of poverty was the cutoff for pregnant women and children. But this 44% is just an average. Some states had much higher cutoffs. Some states actually had lower cutoffs. You can also see on the left side the dollar amounts that are associated with those income levels. So here's what the Affordable Care Act did. If you look to the bottom right of this slide, you'll see that the law required an expansion so that everyone under 133% of poverty, 33,000 for a family of 4, 16,000 for an individual, would be covered under Medicaid. And to date, that has brought an additional 14.4 million people into Medicaid, many of them because of these new eligibility categories, including childless adults, but also because with increased awareness that came with this expansion, people who were already eligible over here ended up, toward the left of the chart, ended up coming into the program as well. Okay, on top of the Medicaid expansion then, if we go back to the slide, what you'll see is that the insurance exchanges became available for people who were up to 400% of poverty, where they can get a subsidy. Then I'm going to add to that there's a group of people who would be above 400% of poverty, not eligible for a subsidy, but still can purchase their coverage through the exchange. And you see the numbers as of 2017 for that. These are people who, if they do not have an offer of insurance coverage from their employer, they can buy that insurance, and the people in this blue area get a subsidy that's based on a sliding scale to make the insurance more affordable to them. Now, after the Supreme Court decision on the Affordable Care Act, Medicaid expansion became optional to the states rather than mandatory. As you can see from this map, while most states have adopted the Medicaid expansion, there are still 14 states that have not expanded the program. So what happens in those 14 states that have not adopted the expansion? Go back to the same chart, and we see, again, prior to the coverage of the law, what eligibility looked like typically in those states. You still had the exchanges available to those folks, so they are able to purchase through the exchange, except the law was written in a way that those subsidies would not be available below the poverty level, because the law was written when it was assumed that Medicaid would take care of everybody before the Supreme Court decision. What that did then was to leave a gap. What it meant was that these childless adults that are below the poverty level would not be covered, as well as, depending on the state cutoff, as well as many parents and caretakers. So here's a few more issues then, or elements that make this all work, especially the coverage piece in the exchanges. The insurance reforms. Health status cannot affect the premium. So we've gone back now to this idea of community rating, where you no longer base premiums on the health level of the people that you're insuring. There are a couple exceptions to that. It is based on where people live. It's also based on whether or not they smoke. But other than that, it is largely indifferent, the premium level, to their health status. There are 10 essential benefits, so that there'd be some standardization of benefit packages, and then also preventive care is available on a first dollar basis, meaning that certain kinds of preventive care would be free and completely paid for. And then, importantly, guaranteed issue, where anyone who applies for the coverage gets the coverage. And then there's risk adjustment, which is a way for the insurers that are competing in the exchange, if one of those insurers happens to end up with a population that's much sicker and one ends up with a population that's a lot healthier, there's an adjustment process where money is taken from one and given to the other. That's called risk adjustment. It's also in the Medicare drug program, the Part D program. And it's necessary because if by design or just because it happens, insurers end up getting more than their fair share of people who are significantly ill, of course it makes the whole deal untenable for them. So there has to be some way to make that kind of an adjustment. Then there's the individual mandate, which brings in the healthy to keep premiums affordable, and it pools the risk across everybody. When you think about it, when there's employer-based insurance, works well because there are large enough pools in order to spread risk when there are certain people within that large pool that have high health costs. The only way you can really keep insurance affordable is to have healthy people in the pool as well as those who are sick. That's why the mandate is so important. It's a very unpopular provision, as we know, but if you have guaranteed issue, where anybody can get that coverage, you're going to create an incentive, of course, where somebody who's uninsured and healthy says, I don't really need it, I'm not going to get it, but once I do need it, I'll go ahead and sign up. And what happens then is with that group of people withholding getting covered, that causes the insurance companies to raise the premiums for those in the pool that are a little sicker. Once the premiums go up again, then that makes it less affordable for health people again. Then it's a sicker pool, the healthy people are out, the premiums go up again. That's known as the insurance death spiral when it gets to be severe, but it's the reason why you either have to have an individual mandate or you've got to have some other mechanism that gets the healthy people into the pool. Now what these insurance reforms do, and the whole design here with the exchange, is to create an environment where competition is based on quality and price among health plans rather than risk selection. Turn the incentives around. Instead of trying to attract the healthy and avoid the sick, the competition within the exchanges is designed to be based on the price and quality of the plans. We will come back to this issue of risk selection throughout the course because I believe it's one of the key questions everybody needs to ask whenever you hear about possible replacements for the Affordable Care Act, what it is we do with health reform in the long term. You always have to come back to this question of how you avoid this phenomenon from happening. If it's not an individual mandate, it needs to be something else. And we'll talk more about that at the intensive. So we've got some variety in the class, which is nice. It allows us, I think, as we get into our discussions to reflect on what's happening in our own states because we've got, among all of you, some states that did expand Medicaid and some states that did not. We've got some states that are using the federal exchange versus their own state version of the exchange, which was an option they had. One thing you'll see right away from this chart is that there's already a pattern to be expected where those states that did the Medicaid expansion do end up with a bigger drop in general in their uninsured population. Notice that because Patrice is in the system office for SCL Health, I included here all three of the states with SCL presence, the most interesting of which right now is Kansas because that state is currently in a contentious legislative effort that could eventually lead to Medicaid expansion. So let's go to payment and delivery system reform. It's the second major component of the Affordable Care Act. The law created what's known as the Center for Medicaid and Medicaid Innovation. $10 billion allocated over 10 years for experimentation and testing of various pilots to try to get costs down by rewarding quality and efficiency rather than volume. There are two ways this is done. One are the involuntary methods, pay for performance. So this is important for all of us to know because it affects the systems and hospitals that we work for. First of all, readmission penalties. For a certain set of conditions, if a hospital has a higher than expected level of readmissions, they are penalized. Value-based purchasing are a series of indicators on quality, efficiency, and patient satisfaction that when you combine them, the hospital gets either a reduction of up to 2%, or it can earn back and get an increase in their payment of up to 2%. There's a 2% withhold, and they can get either penalized or rewarded depending on their score. And then penalties for hospital-acquired conditions, things like falls, bed sores, certain kinds of infections that are acquired in the hospital. Those are required. Then there were the voluntary programs. Accountable Care Organization, that's a group of physicians, hospitals, and other providers that have agreed to contract with Medicare in a way that if they can coordinate care effectively, and if they, by doing that, can bring the per-person cost down of the Medicare population they're serving, then they can keep part of the savings. Part of the savings goes to the government. They keep part of the savings if they can bring down costs sufficiently. They're not paid any differently in the system. The physicians still get their fee-for-service. Hospitals still get their DRG payments. But the incentive is if they can work together effectively, they can bring those costs down and then share in some of the savings. So it's often called the Shared Savings Program. Bundled payments under today's system, if somebody has a knee replacement, hip replacement, heart bypass surgery, you can only imagine all the different pieces that occur and all the different providers that are involved. There's the diagnostics, there's the different specialists, there are the medical devices that would be involved, the aftercare once the surgery takes place. All of these things, of course, under our current system are paid for on a piecemeal basis, fee for service. Each of them, each service, each part of that procedure paid for separately. Bundled payments, the idea is that there's a single dollar amount. It's administered in various ways, but the concept is single dollar amount for a particular procedure from beginning to end, which again creates an incentive for those providers to work together, because if they can keep their overall costs down by coordinating the care more effectively, using the most cost-effective approaches while still sustaining quality, then they do better financially because they can bring their own costs down under the amount that they're getting paid. These have been voluntary. CMS actually was in the process of moving toward a mandatory part of this program for a randomly selected set of hospitals across the country, hospitals and physician groups, where this was going to move into a mandatory phase, but that's been on hold for a while and has been postponed under the Trump administration. And then there are other innovations as well. So here's how this stacks up for both hospitals and physicians. I'm going to start with the hospital side and just build this up to show you the payments that are at risk on a percentage basis. Starting with hospitals, value-based purchasing, that program, we're based on these indicators. You can either get a 2% bump or up to a 2% bump or up to a 2% demerit. Then there are the readmission penalties that add a whole nother percentage to the payment dollars that are at risk. Those penalties apply to all Medicare payments, even though the measures themselves are based on a limited set of procedures. Then there are the hospital-acquired conditions penalty. And then finally, meaningful use of electronic health records. This was actually part of the stimulus package that was passed
before the ACA was passed,
where there's a whole set of processes in place for hospitals and physicians to adopt electronic medical records and use them effectively or use them meaningfully, and a set of requirements around that on an incremental basis that also involves potential penalties and rewards. So then for the physician side, you have something fairly similar. Like hospitals, physician reimbursements have been affected by a value modifier shown here in orange. So physician pay as of 2017 was raised or lowered by as much as 2%, depending on how they scored on a series of quality and efficiency indicators. Also, like hospitals, physician pay was affected by their level of participation in the Meaningful Use program designed to incentivize the effective use of electronic health records. We will see in a moment that physicians are currently transitioning to a new program, but this is how the pay-for-performance system worked for them in 2017. So let's go back to the full slide again, where you can see that the overall intent here was to use similar incentives for both hospitals and physicians to help drive the overall system toward better and more efficient care. Now, notice that this slide is labeled for the year 2017. This is in part because these various payment incentives for both hospitals and physicians were implemented gradually over a 4-year period, culminating in these particular final percentages for the year 2017. Now, hospitals are still subject to these same payment risk levels now, this year, but the situation is currently changing for physicians. This is where the physician piece is changing now. We'll talk about more when we get to the Medicare week of the course. In 2015, there was a law passed called MACRA, the acronym for it, that was designed to replace what up until then had been the sustainable growth rate formula. The sustainable growth rate had been in place for over a decade and required Congress to reduce Medicare payments to physicians if a certain threshold was exceeded in outlays for a year. It was repeatedly postponed or overridden by Congress over the years. It became very problematic, and finally in 2015, Congress replaced that with a whole new approach that has built into it certain payment increases for physicians, but bases them now on a whole new quality and efficiency program. And again, we'll talk about that later in the course. This particular measure is one of the measures used for both hospitals and physicians. And I just want to touch on it because it is so emblematic of what we mean when we say we're trying to shift from a fragmented system to one that's more integrated and coordinated. It's called the spending per beneficiary measure. And what it says is that CMS takes everything it spends on a particular patient that's been in the hospital 3 days prior to the hospital stay itself, and then 30 days after the hospital stay. It looks at that total amount, compares to averages across the country or regionally, and then you either get rewarded or penalized in the payment system for this particular measure depending on how you're doing. So think about what that means, because it's everything that gets charged to Medicare within this time frame. I have a colleague where I used to work who used to say, you know, we as hospitals haven't been terribly good at coordinating once people leave our facility. In fact, we're real good at kind of getting them in a wheelchair, getting them down to their car, and then after that, it's over. Now you're in a situation where you've got to be paying attention to what happens at the nursing home or the rehabilitation center or at home. How is it that we can work more effectively with those organizations to try to reduce overall costs? And you're into a whole new mode about coordinating in order to score well on this particular measure. Physicians have this built into their pay-for-performance system as well. So finally, the financing piece.
The ACA was financed largely through these three sources, starting with payment reductions to providers and private Medicare health plans. Secondly, there were a series of taxes as shown here, although 3 of them were delayed in recent years and then finally repealed at the end of 2019. And then there were penalty payments from large employers that chose not to cover their employees and from individuals that opted not to obtain coverage. We will see in a moment that the penalty amount for the individuals was recently reduced to 0 by Congress, so this is no longer a source of financing for the law.
The important piece for us here is the fact that hospital payments were reduced by $158 billion over 10 years. And there was kind of a negotiation and dance that went on during passage of the law where hospitals ended up being supportive of the ACA because the thing was structured in a way that the projections showed that the increased coverage, of course, would be bringing more revenues into the facilities for coverage of the uninsured, for the Medicaid expansion, expected dollar amount that was sort of roughly equivalent to this one. So the idea that Congress had was, well, if you're going to be getting that so-called kind of windfall, then we're going to put a series of cuts over time in as well. One of them being around disproportionate share, where there's maybe a little more logic to it because the idea is that you wouldn't have as many uninsured low-income patients, uninsured patients over time. So there are other provisions in the ACA that affect us more directly as Catholic healthcare. We will go into these in more depth at the intensive. I'm just going to touch on them briefly now. There are tax-exempt hospital requirements, especially as they relate to our community benefit work. Secondly, the whole abortion issue was treated in the law so that states could decide whether or not abortion could be included by insurers within their exchanges. And so many states actually then voted that abortion could not be coverage, but a lot of states did not. And then for those states that continued to allow insurers in the exchange to offer abortion, there was a provision that said that that piece of the premium needs to be segregated out. The person purchasing the insurance has to pay it on their own in order to not make use of the federal subsidy as part of what pays for that. A lot of controversy around this, of course, and actually some studies that are showing how unevenly it's actually being implemented. Again, we'll talk about that at the intensive. And then the contraception mandate, where as part of the larger picture on defining what is so-called preventive care, the administration then did draw the conclusion that contraception should be covered on a first dollar basis. It should essentially be free as part of women's preventive services. There was only a very narrow exemption for groups like churches, but not groups like Catholic health systems or Catholic schools or social service agencies. That narrow exemption led to a lot of controversy and finally a so-called accommodation where health systems, in our case, could say to the federal government, look, we have a moral objection to this, and once they've said that, then the responsibility for getting the free contraception to women switches over to their insurer or their insurance carrier so that it's handled through them rather than through the organization. Now, there's been law cases around this and some other movement that we'll talk again in more detail about at the intensive. Now, the ACA was not the only source of reform that's been going on. I mentioned the meaningful use legislation that was prior to the Affordable Care Act. MACRA, very significant, and we'll be talking more about that because of the way it's changing the way physicians are paid over time. State Medicaid programs have been changing. Employers and insurers have been pushing reform as much as the ACA has. The ACA reinforced what was going on, but employers and insurers have been pushing in that direction anyway and have been reinforced by what's in the ACA. And then, of course, our own health systems have been very engaged in delivery system reform. So, how is the ACA doing? This is a very brief synopsis because we're going to be talking more about this next week and at the intensive. But I did want to at least give you a snapshot of where things are with coverage, delivery system reform, and costs. In terms of coverage, since the law was enacted, about 20 million people have gained coverage. And while there was some rough sledding for a while with the exchanges in the early years, a lot of that is stabilized now in terms of participation of insurers in the exchanges, and also the premium levels have moderated somewhat. But there were several years where the premium levels spiked quite a bit, and that continues to create a problem for families that do not get a subsidy. And this is very important because about 83% of those people getting their coverage through the exchange get a subsidy. And when they get a subsidy, they are protected from sharp increases in premiums. This is the way the formula works around the subsidy. But for those families and individuals that don't get a subsidy, the premiums have really gotten to be unaffordable over time, and this remains a problem that we'll talk about quite a bit. It's a relatively small group of people, and yet a very important issue. Even though we've seen big gains in coverage, there has been some erosion recently, which can be linked to some degree to some actions taken both by the administration and Congress in recent years. Now, around delivery system reform, where we're moving the system more toward quality and efficiency through the payment mechanisms. The evidence is still kind of out. The jury's still out on how effective some of those have been. We're seeing some evidence of effectiveness, some mixed results in others, but probably it remains to be seen just how effective these have been. The administration has slowed a few of these efforts around delivery system reform, but for the most part, they've continued to be supportive. And then finally, around costs, there has been a moderation in the rate of growth in healthcare spending. But it's not entirely clear, of course, how much of that would be because of the ACA versus other factors. So here's what's happened with the uninsured over time. The law was passed in 2010. A lot of it didn't really get implemented until about 2014, which is where you start to see the drop in both the number and percentage of uninsured. It went down to as low as 10% of the non-elderly population being uninsured. And you can see that that started to creep back up a little bit in 2017. And there are signs by what's happened in the most recent open enrollment periods that we're starting to see now some continued erosion of that coverage. In the last two enrollment periods, 2018 we saw a slight drop, and then in 2019 more of a drop in the number of people that were enrolling. Some of that can no doubt be attributed to a series of actions taken by the Trump administration and Congress. Not exactly clear which ones have had an effect, and we're going to see more of that over time. Some may have had an effect, maybe not. But the most important thing that has happened on this slide, because we'll talk about some of these other ones in more detail later, the most important thing that's happened, though, is right at the top, which is that at the end of 2017, Congress, in a budget package, did repeal the individual mandate. And as we've talked about, that creates a risk selection problem, or the potential for a problem, because the people who are more likely now to say, hey, I'm not going to get the coverage, I no longer have to pay a penalty if I don't get the coverage, are going to be the healthier people, which then leaves sicker people in the pool and has a tendency to drive costs up. The rest of these recent efforts we'll talk about in more detail next week. And we'll also talk about a change that the administration made in that contraception mandate that we discussed earlier. Now, in the meantime, Congress has been gearing up to respond to some of these things that the Trump administration has done. And they've also been talking quite a bit about the need for a stabilization package, a series of policies that would help to stabilize the ACA further and try to prevent more erosion in coverage that we saw earlier. Everything but the last point on this slide are intended to strengthen and shore up the Affordable Care Act, especially around the coverage provisions. The last item, of course, is something that's come up more intensely as we approach the presidential election and in light of the new Congress, where we're getting a lot of discussion of Medicare for All, various versions of Medicare for All. We'll talk about those in more detail and get into a dialogue around those at the intensive.
Also for exploration later in the course are the various court cases on the ACA, the most important of which is the current Supreme Court case at the top of this slide, known as Texas versus the United States. After Congress voted to set the individual mandate penalty at 0 in 2017, a set of state attorneys general and governors argued that the penalty-free mandate is no longer enforceable as a tax and thus no longer constitutional. Because they believe that the mandate is essential to the rest of the ACA, the plaintiffs asked that the entire law be struck down. The Trump administration is supporting this challenge to the law. The Supreme Court recently agreed to hear this case in their 2021 term, with enormous implications for the future of the ACA.
So this next set of slides are the ones I'm going to skip over. I encourage you to take a look at them. What they are is a kind of series of starter thoughts about the ethics of the Affordable Care Act. And I've structured them around our ethical lens, our ethical commitments. And you'll see as you go through that aligning with those ethical commitments are a number of observations about the ACA. We'll talk more about those at the intensive. I'm always going to be ending these presentations by going back to the class framework. The idea here is for us to reflect, and we will be doing this throughout the course, on what our role is as mission and ministry leaders in helping others in our organizations do these three things. And in this case, with the Affordable Care Act, when we say respond strategically to policy, that means what's our role in helping our organizations do things like getting people signed up for coverage? What's our role in helping to influence our organization's efforts around delivery system reform and responding to those payment reforms? And how do we do that through our ethical lens and in light of Catholic social teaching? Same thing with establishing positions on policy. If we're in a state that has not done the Medicaid expansion, what's our position there for expansion, and how do we approach that? A whole series of other implementation issues. The stabilization package that Congress actually did try to get through a couple of years ago and did not succeed. The ministry took positions on all of these and will continue to, and it's going to be important for us, again, to help our colleagues establish those positions in light of our ethical framework. And then finally, how is it that we engage with members of Congress and our state legislatures around this issue to actually influence policy? All of these things around the ACA we'll be talking about at the intensive. So finally, this is the question we'd like you to work with this week online. You will see in your readings and in your reading the bar book and in this presentation a series of quotes about whether or not healthcare is a human right. I'd like you to pick one of these quotes and then make a concise case for the quote and then go into some discussion. Thanks much. We look forward to seeing you online.